Data doesn't lie, your go-to for the science behind the art of parenting.
Hi guys, welcome. This week, oh my goodness, I'm so excited. I have been thinking about this for a while. The person who's joining us today, she's awesome. Her name is how did I not start with that? Dr. Rachel Kiliod-Fobi. Her CV is lit, but I'm gonna just give you a few hints here and there. She's a maternal fetal medicine specialist. She's an assistant professor at the Oregon Health and Science University. She is the managing director of the Oregon Perinatal Collaborative. And there's more cooking. She's on the board for Planned Parenthood. I can't even go on, but she's also my sister-in-law. That's how I was able to get her on the phone. So y'all know where to call if you have questions. Today, she's going to try to help us answer the one question that we were thinking about. So one of my friends asked, she's about 8 months pregnant. She's a first-time mom, and she's been having a lot of headaches, which is not usual for her. So I thought, who do I know that can help? And Dr. Rachel Kiliod-Fobi decided to answer and help us answer that question. So welcome, Rach. Thank you so much for doing this. And yeah, just jump in.
Hi, yeah, thank you so much. It's lovely to see you. And thank you for the very, very, very warm introduction. It's humbling to have married into your family because it's very impressive. So
I'm something for us that you decided to marry into her family. Trust.
And I have to say my favorite part of my job is kind of the connections with patients, but then professionally it's the connection with subspecialists like you. So I'm very happy to talk about this. And oftentimes we have slightly different takes on what our patients are experiencing or the clinical questions that they get. So there's always value in different disciplines talking to one another and having these conversations about what's going on.
Yep. Mm-hmm.
I think the main thing that always comes to bear is that normal things can be normal in pregnancy, but things that are a little bit atypical or mild symptoms outside of pregnancy can also be very serious. And having a really good relationship with your provider and thinking about how you access that care and how you talk to your providers, I think is really important in trying to figure out what is normal and what is not normal.
Right. So what I'm hearing you say is headaches could just be normal, right? You have an outside pregnancy in pregnancy doesn't mean that it could be anything serious.
Right. So your normal pregnancy or normal headache outside of pregnancy, maybe your normal headache in pregnancy, some hormonal changes and some of the cardiovascular changes in pregnancy may make you have more of those. And then how you treat them. So certain types of migraine medications we don't use in pregnancy. If you're somebody who uses the ibuprofen or the NSAID class of medications, we tend not to use those in pregnancy. So how you treat your headaches may also change, and that may impact your ability to control the frequency and the severity of your headache. So it may be that they're totally normal, but headaches in pregnancy, particularly past 20 weeks, can also be fairly worrisome, and for a couple of different reasons.
Okay.
So the first thing I think about is, what is your blood pressure, and whether or not you have chronic hypertension, high blood pressure outside of pregnancy, or blood pressure issues related to the pregnancy. Pregnancy can make those things certainly worse. It's not anyone's fault. I think high blood pressure gets a bad rap, generally speaking.
It really does too, though.
That it's like a lack of self-care, and it's not. And high blood pressure can happen to women of all walks of life, of all BMIs, of all dietary habits, and pregnancy sort of without a lot of warning can cause increases in blood pressure, particularly later in the pregnancy. And again, it's not anything to do with what you've done for the most part during pregnancy. It really has to do with something that happens very early on with the placenta and the uterine wall. So it's totally outside of your control. And the most important thing is having a good dialogue with your provider so that you can acknowledge that. So high blood pressure can, high blood pressure.
I was going to say, that's it. I like the fact that you're highlighting that it really and truly is nothing that you did or have any, it's just the way the physiology works by virtue of being pregnant.
Yeah.
So what else with the headaches would make you think it was a blood pressure issue? Like what else would the mom be experiencing?
Yeah. So blood pressure itself, when it's very high, can cause changes in the brain that people experience, that women experience as headaches. It can cause damage to the blood vessels, and then that can cause problems. So essentially a stroke type of a picture. That's a very severe complication that we don't see very often. We do more often see headaches as a symptom of something called preeclampsia. Preeclampsia affects women differently, but at the end of the day, it is also related to high blood pressure that is mediated or related to that placental interaction.
Right.
It can cause dysfunction in different organs, and the headache is actually from cerebral swelling, so from swelling in the brain. So it's a very serious complication. It can also cause, in its truest form, visual changes, which are also related to the neurologic impact of preeclampsia. It can affect your liver and cause abnormalities in some of the tests that we do to assess that. It can cause severe pain over your liver, which is in the right upper portion of your abdomen. It can cause nausea and vomiting. And so if there's new findings or new symptoms with sort of severe pain and nausea, vomiting, and just generally feeling unwell, I would always want to see somebody for that or hear about it. It can cause your kidneys your kidneys, which typically serve as a filter. It causes them to be less effective, and so you start to spill more protein out in your urine, which is one of the primary reasons that we're testing your urine at your prenatal care visits.
Right.
Yeah.
And how would you? At what point? So you can't prevent it, right? By virtue of just the way it comes about. But what can one do to maybe minimize the risk of having it or minimize how severe it is?
Yeah, that's a really good question. So we're learning more and more, and there is compelling data to suggest that in some women who either have a past history of preeclampsia or high blood pressure in pregnancy, or certain prior adverse pregnancy outcomes, or who have certain risk factors unrelated to a prior pregnancy. So somebody with high blood pressure outside of pregnancy, that taking daily aspirin starting very early on in the pregnancy can help prevent the recurrence or the development of preeclampsia. That's something we don't want women, because again, aspirin is one of those medications that's in that class we typically don't want in pregnancy. And so it's really important that we do this under medical supervision, and that we have anyone who thinks that they might meet this criteria talk to their primary OB care provider. Sometimes you end up seeing for the whole pregnancy a doctor like me, a maternal fetal medicine specialist, one of the high-risk pregnancy doctors. Other times we do a one-time consult, or we've worked so much with your provider, and your provider has a lot of experience in this that you don't need to do that. Yeah, but that's one of the things that we look at. The placenta oftentimes is thought of not as like a maternal organ in terms of affecting all of these different body parts, but as a fetal organ. And so women who have this also have a risk for their fetus. So the most important thing is early, often regular prenatal care. And in the time of COVID, we're making modifications. So a lot of that has to do with teaching women about how to monitor their blood pressure at home, and reviewing what those symptoms are, and having a low threshold to evaluate women appropriately.
Okay.
We're working hard on getting insurance companies also to cover that, so that you can have a home blood pressure cuff. So if you don't have that and you meet these criteria, this is something to be evaluated for. So those are certain things. Some activity modification is helpful in the severity of it, but typically absolute bed rest is actually harmful in pregnancy. And that's only when you have kind of development of these symptoms. Okay. And then at the end of the day, the cure is delivery.
It's delivery, right? Because when I hear, when I'm called to a delivery and that they tell me the mom has preeclampsia, what I'm expecting is, okay, baby's probably going to be premature, because again, delivery is how we treat mom. Baby's probably going to be way less than they should have weighed for that particular month or gestational age. So what would you, and for us, because we're used to it, I can tell the mom, the baby will do well, we'll spend some time in the NICU, yes, but for the parent, it might be scary, and like, I don't want my baby in an ICU, like what what would you say to moms who do have hypertension in pregnancy, how to potentially have a successful pregnancy, hopefully getting them to term? Even though we know that we want to deliver as soon as possible, like what are the things that one could do to say, maybe we try to get you to term versus, you know what, it's safer to just get the baby out now?
Yeah. So the timing of delivery is always related to the severity of the symptoms and the severity of the blood pressure. And so it really takes a lot of thoughtful consultation and discussion and observation. Sometimes we do that with inpatient managing and monitoring, and sometimes we do that outpatient. We do keep a close eye on fetal status also, because we're only prolonging the pregnancy when it is reasonably safe to do so. Because we're trying to get to a later gestational age. And so when we have high blood pressure of any type that's related to the pregnancy, so gestational hypertension or preeclampsia at 37 weeks, which is about 3 weeks before the due date, but is thought to be at term, we generally recommend delivery. Now, in women who have no complication, 39 weeks seems to be a sweeter spot for women who are interested in an induction of labor when we think about sort of the risks of going later in pregnancy and then the risks of prematurity. But there's lots of variation around that, and that's from sort of larger population-based studies. So there's no one size fits all for the most part. But when you do have risks to a woman in her pregnancy related to the pregnancy, at 37 weeks, we think that the benefit of prolonging a pregnancy for fetal indications isn't worth that trade-off, because babies do very well, even if they're smaller.
Yeah.
Before that, it really depends on a lot of things. So the severity, how far along a woman is, what the baby is doing. Because in some cases, when a woman has preeclampsia, issues related to what we call placental dysfunction, the placenta maybe being the instigator of all of this, then you also have growth abnormalities. Not always. Some babies are just going around, testing looks good. But the important thing is knowing that it's happening, because even if we prolong a prepregnancy, we can optimize outcomes for the baby by giving the medication that neonatologists like to see. Depending on the age. Yeah, well, we like to see too. But to reduce the harm of prematurity, we can't totally eliminate it, but there are some things that we can do. And it's this sort of very delicate balance between the harm and the benefit of both the woman and her baby. And we you know, almost every woman that I work with would take harm.
The harm, exactly, as long as the baby's healthy. Oh, yeah.
And we cannot have a healthy baby without a healthy
woman. A healthy mom. Oh, yeah, completely agree.
And so that balance, I think, is really hard, but really talking about it and then making sure that there's trust and making sure that you're in a facility that has capacity to care for both the woman and the baby, and that has a lot of comfort around this and experience with that, and how to ask those questions and what to say, I think is going to be different for everyone, but it can be really scary, especially if you get transferred to a new institution and you don't know all of your providers, and sometimes you meet a different person every day on teams that are in big medical centers with a lot of subspecialists. I do think the advantage to that, though, is that you get a lot of thoughtful people considering you and thinking about you and communicating with you, and you may bond differently with them and receive or hear the information differently at different points, or framed a different way.
Right. My last question is there, I don't know that a lot of people know this, but I think it's worth mentioning that even though baby has been delivered, do moms still have symptoms of pregnancy, of hypertension and pregnancy, or related to pregnancy? Because she's no longer pregnant, so you would assume that high hypertension is magically gone. What would that look like for her? What is her risk in that particular scenario?
Yeah, that's a great question, and I really appreciate you asking that, because a lot of times society, healthcare providers, other folks stop thinking about women as soon as
as soon as the baby's out, you should be magically well. Get up, go feed.
Typically, the highest risk to all women, even without preeclampsia, is during their reproductive years, is pregnancy related, and that risk really is in the time of delivery and then the first 6 weeks postpartum, although it can extend up to a year. Typically, the management of women with preeclampsia, or women with like headaches and the blood pressure issues, which is how they get the diagnosis of preeclampsia, is to continue them on some medications after delivery to keep their blood pressure well controlled as they need it, and then also to prevent them from having a seizure, which is related to the preeclampsia and that swelling that we talked about. Those medicines don't feel awesome. They feel pretty lousy, and everyone always wants to hasten the recovery process. They want to be bonded with their baby. If their baby's in the NICU, that feels worse. It doesn't mean that they had to have a C-section. You can have a vaginal delivery, depending on how your clinical course is going and what your experience was. But either way, even recovering from a vaginal delivery, there's still risks associated with that. We typically like to do a little bit more blood pressure monitoring. We'll typically recommend that women go home with a blood pressure monitoring cuff if they hadn't been on one before. We'll typically have even more observation than the standard in the hospital that most women have without preeclampsia. And then we usually have women come back in sooner rather than later to be evaluated by one of our nurses or by the clinical staff. So that monitoring afterwards is really important. Women with high blood pressure in pregnancy, preeclampsia, and then to a lesser extent, women who never had issues during their pregnancy are at risk for having the development of preeclampsia in those first 6 weeks. So some women do get readmitted to the hospital with sort of new elevation of their blood pressure even after the placenta is delivered. But that's a smaller cohort of women. And then some women who did not have high blood pressure going into the pregnancy sort of unmasks their chronic hypertension.
Chronic hypertension, right.
Yeah, and so some women, most women end up off of all their medications by the time they're at 6 weeks postpartum, but some women end up on medication for the foreseeable future. And the important thing to remember is that any woman who has preeclampsia or high blood pressure in their pregnancy is at risk for having it happen in a future pregnancy, but because women are more than just vessels for pregnancies. It's also a lifetime risk of cardiovascular disease. And so making sure that your primary care provider knows that, whether that's somebody that you saw for your obstetric care or not, hey, I had this history, I had this experience, my blood pressure is normal now, but what things can I do in terms of screening and then lifestyle changes, behavior changes to reduce my lifelong risk of having cardiovascular disease?
I think that's just an awesome point to end on, being that we're more than just vessels for for babies, and making sure that we're healthy too. Thank you so much for joining us. Thank you for answering our questions at this point. Thank you. You guys, if you have any questions, please don't hesitate to ask. I'm going to put links in the description box below, ways to reach me, ways to reach Dr. Piliotobi. Don't hesitate at all. I have the in with her, so please ask all your questions. I'll make sure she answers them. Thanks so much, Rach.
Thank you, and thank you for doing this. What an amazing service for women when there's so many questions about their pregnancy and their babies. So I know I've listened to all of your
Thank you so much. I know it's been an experience, but I'm enjoying it so far. Yes, I'm finding that I'm growing through it too. So yeah.
All right.
Talk to you later, Rach.
Sounds good. Bye.
Okay, bye.